Okay, it's 1 o'clock. Let's go ahead and call the meeting to order, the Hearing Aid Dispensers Committee. Would you like to call roll, Sharice?
Yes. Mr. Borges?
Here.
Mr. Danduran?
Here.
Dr. Sanders?
Here.
Dr. Chambers?
Here.
Dr. White?
Here.
We are all here and have a quorum.
Thank you very much. First item on the agenda is public comment for items not on the agenda. We don't have anyone in the room here. Do we have anyone online?
Yes, we do, and we're going to begin with instructions. So, for those who wish to make a comment for items not on the agenda, now is the time to raise your hand by tapping the hand button at the bottom of the screen. Dial-in users dial *3 to raise their hand. And for our mobile device users, you may need to hit the ellipses button, that's the ... in order to find your hand button. You have 3 different pages, and only one of them has that hand button. People will be given 3 minutes to speak, and I'll give you a 30-second warning before your time expires. We're going to take just a few more seconds now to see if we have a request for public comment for items not on the agenda. Seeing no requests, do you wish to continue with the agenda?
Please, thank you. Okay, so item number 3, what we're here for is discussion and possible action regarding post-fitting counseling and foreign body in the ear canal as stated in Business and Professions Code sections 2538.11, 2538.36, and 2539.6, and Title 16, California Code of Regulations, sections 1399.125 and 1399.126. That would be the HAD 3 tab in your binder. Maria, would you like to give us some background?
Thank you, Mr. Borges. On December 1st, 2023, the committee delegated 2 committee members to work with staff to draft regulatory language that would define the terms post-fitting counseling as used in Business and Profession Code section 2538.11 and foreign body as used in Business and Profession Code section 2538.36 and 2539.9, and permit hearing aid dispensers and dispensing audiologists to remove hearing aid stones, which is in attachment A. This is in response to an inquiry the board received in July 2022, asking whether there is any statutory or regulatory language that would restrict a hearing aid dispenser from performing a dome removal if appropriate training is provided and appropriate safeguards and policies are in place to limit dome removal to lower risk clients. The committee also directed board staff to research why Business and Profession Code section 2538.36 was added. Board staff believed that this was intended to mirror the provisions of section 801.420 of Title 21 of the Code of Federal Regulations, which requires hearing aid user instructional brochure to contain a warning statement that a HAD should advise prospective hearing aid users to consult promptly with a licensed physician before dispensing a hearing aid if the HAD determines that the prospective user has any of the 8 conditions listed. However, Title 21 of the Code of Federal Regulations, 801.420, was repealed in 2022 when the Food and Drug Administration established a regulatory category for over-the-counter hearing aids. FDA has retained some of the language, which you can see in attachment B. The first 6 conditions have been part of the California statutory language since 1971, when the Hearing Aid Dispense Examining Committee was created within the Board of Medical Examiners. The last 2 conditions were added as a result of a technical cleanup in 2010. Federally, all 8 conditions have been a part of the regulatory language since 1977. Board staff believes that the first 7 conditions were developed by the American Council of Otolaryngology, known as the American of Otolaryngology Head and Neck Surgery, for use as a screening procedure for dispensers. The last condition was added in response to public comment on the proposed federal rulemaking. We have provided materials and would like the committee to review and discuss them and determine if any clarifications need to be made to the proposed text included. Thank you.
Thank you. So in essence, we're trying to come up with guidelines for dispensers to be able to remove domes from patients' ears without necessarily having to refer them to a doctor or urgent care or emergency room to have it done. If we look at I'd like to kind of go through it, and then if we can talk about it, because it's just a little bit here, if that's okay. Post-fitting counseling, for the purposes of section 2538.11 of the code, post-fitting counseling means adjustments and servicing of a hearing aid or aid sold, removal and replacement of a hearing aid that is malfunctioned or is no longer operational, resolving client issues including physical fit and acoustic targets, and educating the client on optimizing communication while using hearing aids and accessories. Post-fitting counseling also includes removal of the hearing aid dome. And then the two, just full disclosure, the 2 people that were designated by the board was Amy and myself. So we kind of went over a few things that we wanted to be able to present to the full board, and then let's get everyone's feedback and decide where we want to move forward with this. So,
Sorry.
go ahead.
So just that first part that you just said, removal of a hearing aid dome from what? Like from a hearing aid, from a,
Right.
right? So do we need to be more specific?
Do we have to clarify from an ear canal?
I will defer to my reg counsel to see if that's necessary.
Similar to how it's specified in the second page, 1399.126, the
Right.
recommendations there has in the ear canal or earlobe.
I think we can move lobe. Okay. Good.
So I will note that change.
That's what I was looking at. Yeah. Any other questions about part A? Okay. Then what we're looking at is what the hearing aid dispensers can do. A licensed hearing aid dispenser or licensed dispensing audiologist shall not remove a hearing aid dome unless they receive written verification from an otolaryngologist certified by the American Board of Otolaryngology or licensed audiologist that the dispenser has performed and is competent to remove the hearing aid dome. And should we put from the ear canal again there each time, or should we make assumptions?
Well, if you're clarifying it in A,
Then we're good
just
going forward.
clarifying
Perfect. Okay.
when you
Just
can
want
do
to make
it.
sure. Okay. The written verification shall be maintained in the personnel file of licensed hearing aid dispenser or licensed dispensing audiologist. So in essence, the dispenser has to get approval from a doctor or an audiologist that they know what they're doing to remove the dome.
So the confusing part here, I think, is that on B, we have, okay, a licensed hearing aid, we're grouping dispensers and audiologists
Yes.
together. And then in 1, we're saying, okay, they have to get verification from an otolaryngologist or a licensed audiologist. But
Right.
then why are we saying audiologists have to get verification?
I was gonna, you beat me to the punch on that one.
Yeah.
You're using that, you're saying they have to get, can't do it unless they go to another licensed audiologist to get approval to do it.
Which I think for us made more sense when we're talking about the hearing aid dispenser.
Correct.
It's
Yes.
a little wonky for the dispensing audiologist.
I have to create a C saying that licensed dispenser shall not remove a hearing aid unless they comply with 2 or
Like separate separate licensed hearing aid dispenser requirements from audiology requirements? And I guess that is the question for the team is, are the same requirements that are being placed on dispensers being placed on audiologists or not? And if we're saying a dispenser needs to go to a licensed audiologist to get signed off on, then we kind of aren't. And we're saying it's different. So what are the requirements for an audiologist to do it, if any? And are they different? And how do we want to differentiate that?
I feel like it's two separate things.
Mm-hmm.
They're not the same.
Okay.
I mean, I think this speaks to, as I looked at it, this was speaking to what dispensers can do and how we get dispensers basically checked out, approved to be able to do it.
Mm-hmm.
That's what I was looking at. Now, if we want to then add something for dispensing audiologists, I think that is a separate issue, if it even needs to be an issue.
So my question with this is, though, I mean, we have all, both audiologists and hearing aid dispensers, historically, have been told, go to the ENT.
Right.
Or urgent care to get it removed. What now separates the hearing aid dispenser and audiologist? Because either one of us are ENTs. So are we all getting it signed off by an ENT? Question number one. Question number two, you're an otolaryngologist, so you know. I've done this for a long, long time, and we've had audiologists that have worked in the clinic, and we've had the conversation with the ENTs. They do not want to sign off anything. They just don't want the responsibility, or they don't want the liability.
Right.
Like, you're going to do what? Unless they really, really, really know you, I don't think that this is going to help change this, is what I'm getting at. Because I don't know that there's very many hearing aid dispensers and dispensing audiologists, unless you're working in an ENT clinic, that the ENT is going to sign off on it. I just don't think it's going to happen.
So I can provide the example from the speech side. So speech language pathologists statutorily are allowed to do flexible endoscopic evaluations, the fees, swallowing evaluations, and they have to do the 25 supervised procedures and get signed off by an otolaryngologist with the written certification. What we hear during the meetings, during the legislation changes, was that oftentimes this means they all get together, there's one ENT in the room, there's a bunch of speech pathologists training and doing the passes to do the training to get the written certification over, I think it's like a day or two or a weekend. Don't ask me how they get that many people that want to get passed through, but it sounds like that method has been what works for them because of the scarcity of otolaryngologists to sign off. So it becomes this, come to the training program, do your training, do your supervised passes, and then you get your written certification.
Love that.
It's not an ongoing,
Yeah.
you have to have an agreement with the doctor.
Yeah, so you get your one-time certification, and then you are okay to practice. Obviously, maintain your competency, take classes to do so, but, you know, the rest.
But that also works under the premise that you're going to find an ENT doctor that's willing to do that.
Which is why we also wrote about it.
Which I was assuming Dr. Chambers was just going to go on the road, charge $100 a pop, and, you know, have a whole new revenue stream. But, well, so then, well, and then that brings up the question: is that something we want to continue to pursue? To look at you having to go to an ENT doctor to get certification for doing this, or is there another route?
Well, the way we wrote it was, or an audiologist. And the reason we wrote it that way was because an audiologist does have extensive training on removing Wusterman management and all of working in the ear canal as part of our doctoral program. So the whole, I think the way we were trying to thread the needle between
Both sides.
Correct.
Because you both have the same statute and the same
Correct.
restriction at the moment.
And we technically still have a an inability to perform, any of us, instrument management without an agreement of supervision from a physician, the way it's written in statute, correct? We can't change that. But the purpose of this regulatory change, correct me if I'm wrong, is to kind of carve out the hearing aid dome as not being under that umbrella of like Struman management, so that we could mitigate the need for that supervision requirement from a physician on any of us for it. And then in our discussion, again, just came up, well, gosh, audiologists, we already are trained on all of those things, so why don't we allow for an audiologist to help train the dispenser to sign off on it, because that'd be a heck of a lot easier to gain access to than a physician to go and sign off for it. And that's, I think, how we came up with this.
Which would then, we need to remove the dispensing audiologist language.
From here.
From here.
From B.
Right, so that way it is clear that the throughput is going from dispenser to audiologist.
Now,
that's what we're talking about.
the difference speech-wise is that many of the speech pathologists that kind of pioneered the fees doing that now also provide the training. So the recent change in the law was that, you know, some of them need to be supervised by the ENT, and then after that, a speech pathologist who's certified to do it can also do the training for the other set of them, right? So that helped relieve the pressure of needing the ENT there for all 25 passes, right? Get your training from the ENT for 10 of them and then move on to the rest. So the option of having an audiologist who's got extensive training in it seemed to be the idea, to add that on so that you can get it from one or the other.
Are you comfortable with this as an ENT?
So the dome, I'm thinking that this is like the kind of outer.
So the dome, right, so what happens, so sometimes when you take the hearing aid out of your ear, the dome gets left behind. And, yeah.
It's pretty small.
It is, but what we're also, and we haven't gotten to that part yet, but how we determine the limits of what hearing aid dispensers can do, and there are limits.
Like not have to be visible without an otoscope. Like you have to be able to just be able to look and see it sitting there.
Right, visual it with the naked eye.
Yeah, that was actually the one that I started about with that otoscopic inspection.
Right.
Now I think that is so.
Yeah. I mean, in essence, we're not going any deeper into the ear canal than what we would, we're going less deep than what we would putting a dam into their ear, or for that matter, inserting a lyric hearing aid into their ear and then going in and pulling it back out again 3 months later, which we can already do without any certification whatsoever. I don't have to go to a doctor or an audiologist for them to check me out to take a lyric out of their ear. The manufacturer rep comes in and they show you how to do it, and then you just do it. This is actually less invasive than that. So then that's, and I was going to lead up to that as we're looking at what we're required to have. You know, I don't want to go overboard for something that is actually much simpler than what we're already doing theoretically on a daily basis. So.
I would say we're trying to clarify, you know, the statutes that restrict those things were also created when there wasn't a small rubber dome in an ear.
Right.
You had a very different thing that was called a hearing aid, and there was no lyric.
Right.
And
Right.
so it's trying to kind of use the regulatory process to what we can to clarify, you know, this is part of the hearing aid. If you can remove a lyric, you can remove this.
Right.
But there needs to be limits, and how far does it go, and what kind of training?
Because it's the whole, is it a foreign body, not a foreign body thing? But yeah, so.
If we do find that yes, I like the idea also. If it is visible, if it's this side of the second bend where you can look in, fish it out, and that I think. And if I do like the idea of the certification as well, some sort of, hey, you got signed off on it. Obviously, AUDs today are, you guys are schooled on this, so certification coming from this side, unless you feel that it should be a requirement from an ENT. But then you'll have to do the dog and pony show.
Boy, you are going to be very, very busy.
And I think also if it says here the minimum of supervised by somebody, that in the previous one, but just kind of stipulating that.
Well, and I think it should be less than 10 personally, but before we move to that, are we comfortable with removing the licensed dispensing audiologist and just focusing strictly on licensed hearing aid dispenser? So we're comfortable with that? Okay.
I think you may want to add a C section to clarify what is the dispensing audiologist part that is allowed.
I'm sorry, just to clarify that an audiologist is allowed to do
The
it.
dispensing audiologist is okay to do it as well.
So, so I have noted that maybe we want to make sure that they comply with B3 and B4. So that's what I have noted for dispensing audiologists.
Meaning as a part of the training, the certification that they're complying with B3,
That they
B4?
it doesn't sound like they would need the verification because it's almost part of their
It's part of their
degree.
degree
So they would
training.
just need 3, not 4.
They would be 3 and 4, which are
No.
You only consult when there's contraindications in the deformity and the active drainage.
Right.
That was the 2 safety precautions
Oh,
part.
consult with,
Yeah.
document clearance.
Right.
Yeah.
That they can safely,
That's the
when there's
contraindication.
contraindications.
Right.
Sorry,
Yeah.
you're right. I
It's
agree.
essentially just the safety mechanism.
Yeah.
that's what I'm tracking for a C for.
Okay.
Right.
I do want to, I think that's a point to discuss, a dispensing audiologist versus a non-dispensing audiologist, because let's remember that our audiology licenses allow us to do, we can fit hearing aids, we can adjust hearing aids, we can clean hearing aids, we can do all the same things that a dispensing audiologist can do with our license. We just cannot sell a hearing aid. We can't sign the sale. So that, to limit it to only dispensing audiologists is rather silly.
You don't need the dispensing
I
part.
think the idea was that since a dispensing audiologist is actively doing those things,
Yeah.
and I get what you're saying, but I think that the thought process was, right?
Right.
It's dispensing, so they have experience doing it.
Right.
As opposed to just an audiologist that maybe doesn't do that because they just do testing and they're not anywhere near hearing aids.
Right.
So, and that brings a point, okay, if just a regular audiologist, if you will, who's not working with hearing aids, is that someone that we want to sign off on being able to do dome removal if they're not potentially doing that in their daily practice, as opposed to someone who's dispensing and would be seeing that on potentially a daily basis?
So I would first say that the training is the same.
Right, but training from 8 years ago versus what I'm now doing actively are not necessarily the same thing.
And that very few audiologists, I can very rarely think of examples of audiologists that don't ever touch hearing aids, whether they're dispensing or not dispensing.
Kaiser.
That's what, that's, right, that's my thinking. Yeah. Yeah,
Yeah.
they have a whole department of people who've never, yeah.
Also, was the master's program
Way back when.
way back when? Are we lumping those in with the, are there very many?
Well, they were grandfathered in, so.
They were
I mean,
grandfathered
You
in.
have to, you can't separate it really, I don't think.
All of mine.
Because they were grandfathered.
The reason we're specifying dispensing
Tells you how long
audiologist
ago it
is
was.
because the restriction is on the dispensing audiologist.
Say that again?
So there just is there's already no restriction on regular
correct.
non-dispensing
Yeah, so,
audiologists.
I mean, how the statutory, the practice.
Okay.
It's one of the same in the statute
In the
anyway.
statute, it only talks about the
Okay. All right, so
That's how I
it's a,
communicate when there's inquiries about
Okay.
dispensing audiologists and what audiologists.
so,
So that's why we have to specify dispensing audiologists to permit them.
Okay.
gotcha. Okay.
under the dispenser's license, they're restricted.
Well,
Whereas a non-dispensing audiologist isn't restricted
Right.
already.
okay.
Oddly enough.
All right.
Statutes.
That's the answer to everything. Statutes. Okay. So then, B1, they receive written verification from an otolaryngologist certified American Board of Otolaryngology, or I'm just going to start saying ENT because that's way too much, or a licensed audiologist that the dispenser has performed and is competent to remove the hearing aid dome. The written verification shall be maintained in the personnel file of the licensed hearing aid dispenser, and then we'll strike out or licensed dispensing audiologist there. So then the question is, what does that verification look like? What, are we going to have a standard form that it has to say so-and-so on this day?
We
Or,
don't specify it for the speech pathologist.
okay, so
So
it could just be any piece of paper that says he did
letter,
it, she did it.
certificate, email.
Okay, all right. They,
Well, if it's going in the personnel file, it should be signed, so. That's just
well,
generally.
they receive written verification. I don't know. Should we say written, it does actually say maintained in the personnel file, yeah. But should it say written and signed verification form as opposed to just written verification? Should it specify
Yeah,
signed?
we've never had to specify it on the other end.
Well, I guarantee you probably have.
It's up to you guys, but that's,
I mean, I don't know, from a legal standpoint, does it matter?
Verification from an employee may imply that it's signed, but including that it has to be signed solidifies that that's the requirement.
Right.
Oh, sorry.
it's okay.
Just yell.
Yeah,
You want
just
me
yell
to
this
repeat
way.
myself?
Could you?
Okay. Oh, I said, because it says that it, requires verification from an ENT, it could be implied that it is, signed by the ENT, but, including that it is signed, it makes it clear, more clear.
Right.
Or
Yeah.
certified as well with.
Yeah, I'm not a big fan of implied. I'd like it to be clear.
Verified,
Not-
certified, oh, no, the
I
certified,
almost got on my
but
personal.
they're a certified ENT, yeah. So, written and signed verification.
Okay. That's fine. Any other questions about point one?
Just to be clear, for the American Board of Otolaryngology, is she the same that head and neck surgery as well? Otolaryngology head and neck surgery. Oh.
Just because that wasn't long enough, you guys had to make it even longer.
HNS, dash HNS.
Gosh,
I think I got this from our statutes for.
Yeah, for the fees.
So our
Oh.
fees, okay.
HNS, okay.
We should do that cleanup
Now
next.
you do the cleanup.
Well, we are up for sunset.
Is that next year? Or you're up for next?
We start next year.
Okay.
We'll talk about it tomorrow.
Okay, so then point two,
Oh, sorry.
Yes, ma'am.
7.1, I did want to bring it because someone had mentioned about the timeline for this verification, because it did come up in my review, and someone had brought it up about what if you do the verification but you never actually do it. So is there any concern that there is not a timeline associated with this verification?
as in having to renew it
Right.
every so often?
Mhm.
We currently don't do that for speech pathologists. So it's a one-time written verification, and we don't go back after that. I haven't had anyone bring the question to us, interestingly.
I think they just stay doing that work.
Yeah.
That type of line of work.
Okay, because there was a distinction between, so for some, like the Kaiser doctors that don't actually perform at regular speed.
So oftentimes, we will get the emails or the phone calls that, hey, I'm no longer dispensing. I would like to turn off the dispensing part of my audiology license. I'd like to go back to being just an audiologist, which of course means a lower renewal fee, and you get to renew every 2 years. So when audiologists do want to disable that part of the license, they do call us, and we do take care of that for them. And that's usually how this would work. And so then they'd no longer be a dispensing audiologist. If they want to keep up the dispensing and the cost, the higher cost, but normally that's how it works. We'll get a call, hey, I'm I'm doing this, but I'm not going to dispense anymore. Let's turn it off. And then we just remind them that, okay, but,
What I would say,
5 years.
in this case, we're talking about a hearing aid dispenser getting the training, right? So, and a hearing aid dispenser taking domes out of ears is a daily, I'm sure, nearly daily occurrence.
Well,
So the chances of it, like, not,
a few times, but it's happening with some,
it's happening a lot.
it is happening, for sure.
I don't doubt.
Yeah, I can't think of 3 times in the last 6 months, but it happens with some regularity. Okay. So point 2, perform a minimum, right now it says 10 supervised hearing aid dome removals prior to receiving the written verification specified in B1. I personally think 10 is excessive. I mean, I think 5, well, I mean, I always kind of fall back on the lyric training. I mean, we did like 1. And he's like, okay, you're good. And then off the merry way. But I don't know about 1 or 2, but I think I like 5.
Your dispensing license when you put a photo block down inside one time.
Well, yeah.
One time, shoot an impression and you pass or fail.
If you're good at it.
If you're good at it. That doesn't mean you haven't practiced a whole bunch. So.
Yeah, but, but it's coming out with the impression material, not having to go in after it necessarily, but.
As a forming to say, okay, can I do this?
Mm-hmm.
How many times do you need to do it? Seriously.
Up to you guys. Our example is the speech pathologist, and theirs is 25. And obviously, it's a whole different thing. We're putting a scope through someone's nose. This is very different.
Right.
So, again, your guys' expertise.
Well, I think if you make it too few, then what's the point of even doing it
Right.
in the first place?
Right.
Why are we even doing this whole thing? I mean, if that's how we feel like you only need to show me to do it once or twice, then why are we even requiring someone to get this quote unquote signed off verification form?
Too simplistic, too easy. I mean, you do it once, which is why I like,
Different ears.
which is why I like 5.
Yes.
Because I think it's a decent number where you have to go in repetitively and do it and multiple times to show you're doing it. And it wouldn't take that long to do that. So I don't think I think 10 is excessive and a little, much, but I think 5 is a reasonable accommodation.
I think at least 3, because the way that dome can fall, it can fall any different version of the axis and whatever instrument you're using.
Yeah, yeah.
So, but if it, it can kind of look at the orientation a couple different ways to make sure somebody can say.
Right. Okay. Like 5?
Like 3.
Yeah, I would disagree with 3. Because again, I don't feel like there's any purpose.
I think if there's going to be a certification and you're showing up in a class, there has to be a certain amount of time that you're going to be there. So, what does it take for someone with an otolite and an otoscope to put it in and the next person to pop it out and say, okay, we're going to pop another one in and we're going to pull it out. Okay, we're going to pop another one in. So that whole process might take 3 minutes if you did 5.
Well, and then we get in the nitty gritty is, do they do it? We have to get in the nitty gritty at some point about how you do that training. Is it on an actual human live ear? Is it on a fake, like impression ear? But let's hold off on that because that's going to get, probably a little messier. But let's just, I just for purposes of how many you have to do to repeat it, to say you're competent, especially if you're only going to do it one time and not have to recertify, then I do prefer a little bit, just a little bit more. I just like the number 5.
How hard is it to add this to the dispensing exam?
Well, don't get ahead of me. I was going to ask that was going to be my, at the end of this, that's actually what I was going to bring up is how do we go about? The problem is that's going to probably take years, right? And I think we need something in the interim, to handle that. Because I'm totally right there with you. That's exactly what I was thinking of last night was this should just be a part, since domes are part of our daily life now, this should be a part of the exam, and do it then, and then you're certified, just like taking a impression, and then you're done because it's a part of your license. But that is going to take years, OPES and all that having to get involved. And so,
Just to clarify, we just did the occupational analysis a couple of years ago. So yeah, it's 5 to 7 years after that that we start up the process again, and then
It's more than a couple, because I did it, you did it, we were on that workshop.
it was implemented in 21 or 22.
so we probably
Yeah,
did it in like 20. Yeah. Yeah. I was gonna say it was like,
So you do the surveys and you do the part, and then they
that's
do,
18.
so they'll do the occupational analysis, and then they implement it through a bunch of workshops into the examination.
Right.
So again, it'll be like probably in the next 2 years that we'll start kicking it off from
Mhm.
there. So then it would be a few years after that.
I totally agree. It needs to be a part of the exam.
Okay,
But
so, and the
in the interim, because we're talking years,
Okay.
I think we
So-
do need a stopgap.
So an audiologist can certify, correct?
Mhm.
Yes.
That's what we're going for.
Yes.
So it's going to be a lot easier to set up,
Either or, but yes.
to set this up so we could, I mean, it's going to have some sort of official verification, some sort of class, right?
Well,
That is currently how the speech pathologists do it. So there's a training component, they learn, they do the passages, and then they get their certification at that training.
well, in this case, though, you could theoretically, because there is no set structure, there's no set like lecture or anything, right? If you had an audiologist that was, you know, in your company, like say Costco, they have audiologists that work for them. They could just go into a room and, you know, corral up 10 dispensers and just do it. You know, they don't have to necessarily have yeah, exactly. Hearing light, yeah.
Right.
You know, you have just someone that could just, you know, okay, let's do it in the district and it's done all in one day. So, you know, yeah, you don't have to have something formal
You
per
have your
se.
audiologist down the street that you work with, and
Yeah.
you just go over there and say, hey, can you watch me do?
Yeah, can I, you know, jam 5 domes in your assistant's ear?
So I know it's not the perfect model to compare, but again, for speech pathologists, we don't clarify that there's got to be a training and a course. They all do that best practice model already. I'm not going to say that everyone gets the best, but again, that's generally how this works.
So just to bring it back real quick, though, let's settle on the number so that we don't get that lost in everything else we're talking about.
I'll go 5.
5, 5, 5. Okay. Okay. We already talked about the hearing aid dome being visible without otoscopic inspection and is within the first or before the second bend of the ear canal.
Here.
Yeah. Okay.
Just a question. Because we're already doing what we do to even the ear canal, can we just make the language be, if it's on
Within the first or before the second
or
bend.
the second bend? I mean, because sometimes you need an otoscope.
If they have very small ear canals.
Small ear canals,
Right.
it's got a tight little, you know, corner on it, but it's still far enough away from the eardrum. It's not past the second bend. We do this all the time. We've been licensed to do it. Why couldn't we do that? If it's on this side of the second bend.
This terminology, the second bend, that's, it's interesting. We think about like where the bony canal and the cartilaginous canal kind of come together.
Mhm.
So as long as it's, you know, soft tissue side, then yeah. So I think.
So do we think of,
that's the same.
yes,
I think that's the same.
yes, right, yeah. Since the cartilaginous is before the second bend and the bony is after the second bend, right? Yep. So if we simplify the language and say is before the second bend. Okay.
He's good with it, I'm good with it.
Okay. So we would strike visible without otoscopic inspection and just say the hearing aid dome is within the first and before the second bend of the ear canal, or we could just say before the second bend of the ear canal. I think that's probably, I mean, that's essentially what we're saying. We need to know the limit, and the limit is before the second bend.
Noted. Oh, the limit is the second.
Right. Well, yeah, the limit is just before the bend, yeah.
I think if you are putting the first and before the second,
Yeah, that's a little cumbersome. And where is that exactly at the first
Well, it
before?
doesn't allow the
Yeah.
dispenser to go, oh, it's right here, let me grab it.
Yeah. Okay.
Wait, so are you saying that we would want to keep the within the first?
No. Just go to before the second bend of the ear canal.
Eliminate the loophole.
Right.
Got it.
Right. There. Does that sound appropriate to our legal colleagues?
Yeah.
Okay. Point 4, they consult with and document clearance from an ENT certified by their board that they can safely perform hearing aid dome removal where the patient has contraindications to the procedure. Okay, that's a little bit, were we basically saying if they have these conditions, they have to go to an ENT? Because it feels like it's saying you have to get clearance prior to that, but you don't. You just have to get clearance if they have that. See what I'm saying?
No, say that a different way.
Yeah, okay. That's hard enough to say it that way. The first.
Yeah, I'm sorry, I wasn't tracking what you
Well, I think, so what we're saying is they don't have to get certification from the doctor to say, oh, this is happening. We're just basically saying here, if they have these contraindications, then they have to go to a doctor. That's what this is saying. But when I say they consult with and document clearance from, so are you saying if they get clearance from a doctor to take the dome out, if they have these contraindications,
they can do it.
then they can do it if they have the contraindications?
That's how I read that.
I feel like if they have these contraindications, they shouldn't do it, period. Yeah, I don't think they should, if they have these contraindications, then a doctor needs to do it, right? Because if they have to go to a doctor to get clearance, well, then the doctor should just pull the thing out of their ear.
So must refer then.
Right. And then my question is, do we need to expand the contraindications? Because I'm looking at, so as an
Include the red flag ones,
so as an example,
what about the red flag conditions that already exist? We do have that somewhere in our materials here. FDA was using for hearing aids.
well, but that's a sudden hearing loss in the last 90 days isn't necessarily a contraindication for taking
It's like
the dome out.
active drainage, pain.
Active drainage. Well, what about things like if they have a TM perforation, if they have hepatitis, if they're on blood thinners, right? These things that I'm thinking, have they had ear drainage while, this thing's been in their ear?
I would be careful because while I agree, blood thinners are certainly something to consider. Same thing we learn when we're doing lyric. Again, we all put lyric deep in the ear.
Right.
And that's a big issue with blood thinners, but a lot of patients still have it. If you say a contraindication is being on blood thinners, like, you're not going to be able to do it. Yeah.
Well, I mean, every one of those, okay. Not necessarily, no, but I'm throwing out all these things that I think we should consider as we're deciding what's a contraindication to take the dome out. If we all agree blood thinners shouldn't be one, then that's fine. But I think we need to throw each one of these things out and decide, what we think we should add and what not. And of course, the language has to be necessarily right. Does it have to be up to, but not including, or including but not restricted to, or do we need anything?
No, you can say including.
We have it may include.
May include, okay.
That's the non-exhaustive list.
Okay.
But it sounds like there may be contraindications that could be performed after consulting with a doctor, ENT. So would there be, so these contraindications you say they should not perform it, but with the blood thinner perhaps would fall under this category. So do you want to have a distinction between the types of contraindications?
I don't think we should have two different categories. I think we should just have a category of if they have this, then a doctor has to do it.
Okay, So then 4 should actually probably be a new C. That,
Yeah, that's something good.
oh, okay, because you're gonna make a different C, and then, so a D, and then that they shall not, remove the hearing aid dome.
When the following
Or the-
contraindications
Right.
are present.
Right.
So apart from those two that are there, what additional no-goes?
The other one, I mean, active drainage is suggestive
Bleeding?
of an ear, you know, of a middle or something that's more medial, right? Active ear infection, but even there's not drainage, but let's say that there's cellulitis of the ear. You know, an abscess is not a congenital issue, it's not traumatic, may not have active drainage, but there's an active cellulitis, active infection. So I don't know if you go with the erythema or, I don't know, like if there's like, you know, exquisite tenderness or, I don't know how far you go with the language.
Do we add exotosis?
That's a different one.
Farther down, but
When you look at
Depending on how far down- well, we passed the
2538.36,
second, so,
sub A8, it does have pain or discomfort in the ear. Would that include,
The only thing is
I can't say
Kind of
cellulitis.
get by
yeah.
having,
Having the dome in your ear, yeah, that could cause a discomfort.
Okay.
somewhere kind of in between the two.
Some don't notice it, because I had a guy who had three domes in his ear.
Yep, and had no clue.
Yeah, and didn't even realize it, so.
One, I
Yeah.
think it's hard to even use a tympanic membrane perforation because
You can't
wouldn't
see it.
know.
Right. I mean, other than you ask them, do you have a perforated eardrum?
Well, if historically.
And then if they
do.
say, or it's in your records, in your history, right? So, yeah, but again, let's throw it all out there and let's see what sticks.
Active drainage or other signs of infection, maybe that would help cover big fancy doctor words.
Yeah.
I didn't even want to try to say it wrong.
Yeah. Maria's over there furiously Googling how the heck to spell that thing. Yeah, well, that's true for most things in life.
So other than active drainage or other signs of infection, visible congenital or traumatic deformity of the ear, I mean, those are kind of large umbrellas.
Mhm.
Do we feel like there's anything more specific that needs to be there, or is that sufficient?
The other two categories that are here are dizziness and then hearing changes. Those are the other two categories.
For hearing aid fitting?
Yeah, right, but,
And our statute says acute or chronic dizziness.
So I think if we are
mhm.
doing our job properly, we're asking those questions anyway. As feeling today, what's going on? I mean, if they're feeling that way, regardless of the dome, we're probably.
Yeah, but I like, the more we have documented, the better I like, because then it's very clear rules about what they have to follow
Okay.
for not doing it versus moving forward or not moving forward. I'm more of a preference of eliminating,
Ambiguity.
yes, ambiguity and interpreting one way or the other.
I don't disagree. However,
I knew there was
if I presented to you and I had a dome in my ear and you asked me if I'm dizzy and I'm like, yeah, I'm dizzy because maybe I have orthostatic hypotension or, whatever other things, it likely has nothing to do with the fact that there's a dome in my ear. So if I had a patient come in and they answered, yes, I'm dizzy, would I not take the dome out? Like, what would be the concern for me to then not want to touch the ear and remove the dome if they said they were dizzy?
No, I have no issues. I have no issues with dizziness.
Right.
Yeah. Yeah, I have no issues with dizziness as not being a contraindication at all.
And that's the point I think that you get out of it because you said the second bin.
Right,
So those are the other two
It's just like
categories.
going like this and making somebody dizzy.
right,
I
no.
think that you're saying because you said anatomically that you're away from things that would be concerning.
Okay.
Right, okay.
So then the two that, as we have it, except just adding active drainage or other sign of infection?
Okay, perfect. Okay. So then, I don't think, this is not, part of it, though, correct? The air bone gap on the next page, I'm not,
It is, before we move forward, I did notice that we are adding on subsection C, say that a licensed dispenser shall not remove a hearing aid dome unless they comply with B3, which is they can't remove the hearing dome, or they have to remove a hearing dome before the second bend of the ear canal.
okay.
And then it sounds like we have.
Wait, was that the licensed audiologist?
Yeah.
Licensed audiologist.
Dispensing audiologist must comply with 3 and 4, or just 3? I thought it was 3 and 4.
4 is now being changed, because 4 is now being.
Oh, I see, it's becoming D.
Right.
Which is that they shall not perform this procedure if the patient has these contraindications, which is the visible deformity, ears, active drainage, or other signs of infection. Okay, so that's what we've got. We're tracking on that, and have noted. So the next section was added because we were talking about Business and Professions Code 2538.3, and we already had language definition in regulations, so we're adding more definitions for that specific regulation. So that's why it's in there. So the regulations already had definition for significant ear bone gap, which is a different section in that code. But they're all the same code, referral for medical opinion.
We're just adding, like, spelling out 15 instead of just having 1, 5. Is that how I read it? Like the underlined or the additions? Yeah.
Yeah, so we're cleaning up what already exists there, and then we're adding more to it based on our discussion regarding foreign body.
So do we have to say do we have to say, in order for our regulation adjustment that we're trying to make, do we have to say a complete intact hearing aid or dome of a hearing aid is not considered a foreign body? Because that doesn't seem correct.
Well, we're trying to clarify that by law, you're allowed to fit the hearing aid, which includes insertion of the hearing aid and the dome, right? So removal of it, as long as it's intact and not, busted in pieces, and you should be sending them to an ENT, like there's a battery down in there or something like that, then that's not what the statute intended. The statute had no envisioning of a dome or hearing aid that was in the ear in the first place at the time it was written. So we're just trying to clarify that.
Can we do that a different way than saying it's not a foreign body?
I think the only way you're saying it is it not in terms of 2538.36 and 2539.6. So just in the terms of that definition in that statute.
Okay, so could we say is not considered a foreign body
for the purposes of?
As defined in blah, blah, blah area?
Well, you could, but you already start out the whole paragraph with that. So for the purposes of these two sections, that's what these things mean. So we're just clarifying for the purposes of those statutes, this is what it means or doesn't mean.
Which is not a true sentence.
Correct.
This is a statute. What does that have to do with it?
I mean, I don't know about Dow, but you can also say, for the purposes of these sections.
Right. But is there another term besides foreign body that would be appropriate?
No, that's the proper term. Yeah, that's how it's written.
Statute.
We can't say it's exempted from, we're not.
No, we don't have the authority to exempt it. However, we're already authorized to do the hearing aids and the dome. So again, we're just clarifying. The statute didn't envision it at the time, but if you're allowed to put the hearing aid in there, then you're obviously allowed to take it out. If it's intact, obviously, if it busts into pieces, you need to refer. But same thing with the dome, which is a component of the hearing aid. So.
I get it.
We're trying to thread the needle here.
Sometimes you just have to go, okay.
Okay, so yeah, you're saying as defined already how it's written, that it really is just specifying according to that.
Yeah, it's only for the purposes of that. Outside of that, no.
So you could include language at the, for the purposes of, and then which section, as foreign body means.
It's for both of the ones at the top. is
Yeah,
all.
they're already.
Yeah, it's at the top.
Oh,
So,
it is, oh,
yeah.
so there's,
For clarity, we tried to make it at the top because it applies to both sections.
oh,
Yeah, because there's one.
But I know the sentence itself, it's bothering you, it's Mona.
Yes, it is.
For sure. Just stop looking. It'll get better.
It's not. It's just not good.
Okay. Any other comments from the committee about any of the other sections?
No, not exactly.
Okay.
But just so I don't, I'm worried that I'll forget in 2 years or whatever when the occupational analysis opportunity comes back.
Oh, about
Is there a, I know that that's an independent process apart from the board. I totally understand that. But if the board is raising a question or would it be appropriate for this to be added to the exam and we want that to be explored, or can we ask for that to be explored during the OA, or I don't know, how do we go about
going on the record that we want this to, be considered a part of the exam, basically.
or just so we don't
Again, your occupational analysis, it always has a survey of the licensed professionals.
right?
And we do ask questions out to the field, and OPES coordinates that, Office of Professional Examination Services, sorry. And of course, there could be questions about new areas that have come up in the practice. They're always trying to keep that occupational analysis current.
You're saying remember it for the survey and answer the survey.
Yeah.
There you go. Write a note in your thing to ping in 2 years.
I mean, not to be
So-
pessimistic, but hey, doing all of our regulations takes time, and you may or may not be in the midst of a survey at that point. So,
Real quick, though, one thing I was thinking about earlier that I didn't bring up. Do we want to add anything about the type of equipment that's required to be used to do this, right? You have to use a loop, make sure you specify forceps versus tweezers, or, is there anything, or are we just going to leave it up to the dispensing audiologist and the ENT to train them how they see fit?
I would say the list of tools is rather exhaustive, and what I find comfortable and what you find comfortable and she finds comfortable are all going to be different things.
Perfect.
I don't think.
Perfect. Generally, we don't want to drill down that tight because then it becomes too limiting, but we want to make sure everyone's on board with that. We've talked about that now before someone decides 3 weeks, hey, wait a minute, what about this? So,
if there was a tool that you're not okay with, then you might want to specify
yeah,
something.
needle nose tweezers.
Again, and we all follow infection control procedures, and that's already a whole part of the.
Right. Okay, good. I wanted to get it out there now so it doesn't come back, weeks from now where someone maybe brings that up. So perfect. I'm fine with that. Awesome. Okay. Then if we're all set, I would like to open it for a public comment. If there's any public comments that someone may have for what we have just discussed. There is no one in the room. Is there anyone online who would like to comment on this?
All right, we are open via WebEx for public comment on this very lengthy discussion. If you'd like to make a comment, please raise your hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. And it looks like our first request is coming from Joe Bartlett. Hold on just a moment. We're sending you a request to unmute your microphone.
there. Again, Joe Bartlett. I just want to say I really appreciate that this is a conversation that you guys are having. I know it started last year, and as humorous as it's been and very informative, I think that everything has been just very spot on in the precautions taken for the consumer and the true kind of dilemma that we are faced with of the inconvenience of the consumer to have to go and find a doctor to pull something out of their ear, where we can be certified or trained to be able to do this. So I do just wanted to say I've been following the conversation, and if it came to some sort of courses or something, I know HHP, we do our yearly conferences, and I know that so does AAA, although that's the audiology side of stuff. But we'd be happy to provide training and provide further stuff of materials to be used. That's better. I know Neil knows tweezers are not the best to work with, so at least making sure people understand that's not the right thing to do. But I do appreciate that this is a conversation, because I think it is very important for our industry here. So thank you for hearing me here.
Thank you. And that appears to be our only request for public comment on this topic.
Okay, thank you very much.
You want to do the action requested and get a motion?
Prior motion?
Since we have to,
They,
because we have to
or were
go
you
back.
doing a motion next time when it's clean?
Yeah.
And yeah, that's committee's choice. You can adopt it as amended, or you can have us bring it back.
I'd like to have it. I move that we have the committee or the board bring it back to the committee so we can see it one more time before approving it.
Motion, right?
You don't need that as a motion. We'll go ahead and clean it up and bring it back to you.
I motioned. Okay, well, thank you all very much. Then this meeting is adjourned. Thank you for all of your efforts.
All right, so we'd like to call to order the Audiology Practice Committee. We want to do a roll call.
Dr. White?
Here.
Ms. Chang? Here. Dr. Chambers?
Here.
Dr. Sanders?
Here.
You have a quorum.
So we'd like to open up for public comment for items not on the agenda for the Audiology Practice Committee. There are no public members in the room, so moderator, if we would open up for public comment online.
Certainly. This is the moderator. If you would like to make a public comment on anything that's not on the agenda, you can look for the hand icon and click that to raise your hand. You can look for the question mark icon, click that, type the word comment into the text box and click send. Are there any requests to comment on something that is not on the agenda? And I do not see any requests. Shall I close the public comment feature for now?
Yes, please.
Thank you.
All right, so moving on to our agenda item number 3, which is discussion and possible action to amend regulations regarding general application requirements and speech language pathology and audiology aid requirements. And Ms. Lorenzo, would you like to take us through the review?
Thank you, Dr. White. On September 5th, the Audiology Practice Committee directed board staff to amend the drafted proposed regulatory language that would begin to clarify the scope of practice and supervision for audiology aids, as well as implement the statutory changes for audiology aids. The following changes were made. So in section 1399.15 we had changed the definition of industrial audiology to mean a person who is certified by CAOC and whose primary duty is to assist in a hearing conservation program as described by the section 5097 of the California Code of Regulations. Section 1399.154.1 We are requiring that industrial audiology aides provide a copy of their KOC certification with their application and remove them from exemption from registration. So they will be required to register. And let's see, section 1399.154.8, we made grammatical and writing structure corrections, and we require that supervisors maintain their course completion records of supervision training for 4 years after the renewal period in which it was earned, if they wish to apply it towards CPD's requirement. Section 1399.154.7, we added, we cleaned up the language by adding the word aid after speech language pathology, and revised the reference business and profession code section. We amended section 1399.154.9 to permit indirect supervision of industrial audiology aides who are performing duties for a hearing conservation program. Also amended section 1399.154.10 to require training for an industrial audiology aide to perform duties for a hearing conservation program, as well as we made some grammatical corrections. And lastly, we amended 1399.14.11 to replace tympanometry with impedance test batteries. Also included are changes we made for speech language pathology practices, since they are reviewing these language and we will be doing them both at the same time. Included are the text, the proposed text as amended, as I described with the amendments included, as well as the language to the hearing conservation program in section 5097.
All right, thank you. So opening up discussion on any of these points, I have a few notes, but if you, I don't know if anyone else had anything they want to get started before I just dive into any of the questions that I have. No? Okay. So I was looking, so we do have the 5097, the Hearing Conservation Program, in the back of this, the end of this section. So I was looking at that, and I was trying to understand if it defined any supervision or training requirements for the KOC tech in there, and it looks like, I mean, it certainly doesn't define training that is required to get your KOC certification. It does say a technician who performs audiometric tests must be responsible to an audiologist, otolaryngologist, or physician. So that's kind of their.
Page 2 of page 4.
Oh, I'm sorry. Yes, page 2 of page 4. That's under 3, the very last sentence under 3. It does go through, if you go through all of this, it does say, like, very clearly when the employee must be referred on to an, you know, to be studied by the audiologist or an otolaryngologist or a physician to review problem audiograms. That's like on page 3, number 3, for example. You know, like number 5 on that same page, a physician determines the standard threshold shift, you know, whether it's work-related or not, et cetera. So it does have a lot of definitions on who is responsible for interpreting the different parts of what the technician, or the aide in this case is what we're calling it, the KOC, would be doing. So I guess all of this to say, on our page 1 of what Ms. Lorenzo just read to us, the first dot there, amend 16 CCR section, blah, 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 1399. Do we need to, I guess my question is for this whole thing, do we need to further define the supervision and training of these KAOC aides? Or can we defer or point to this, what's already defined in 5097?
Their training, we defer to the section. That type of thing. That's how we have it written.
Okay.
If you look at page 13 of 6, we just specify that it's indirect supervision, so the supervisor doesn't have to be at the same location, but be available.
Okay.
As described as the section, which is that they're permitted to do. And then that's on the same page towards the end, it has similar language regarding provide training to perform the duties. Since we're requiring they are certified by KAOC, it's whatever KAOC determines.
The training. And I guess that was my purpose in bringing this whole thing up. I just want to make sure we're not adding additional work or doubling up on what they already have to go through on the supervisor or on the board staff.
We're deferring to the program to say that we call it indirect supervision. Audiologist is just available and can come in and be in person if they want, but not necessarily.
Okay, so then on page 6 of 16, you have A, and then, you know, like 8 and 9 discuss the duties, and under duties, it does again break out the KAOC certification. Do we need to break out KAOC under 9 as well because of the training differences?
Can you say,
Explain that differently?
Yeah.
I think what she was meaning is that since we called out the KAOC certification in 8A, did we need to also call it out in the training?
I think it refers to the section. So in the section, like if you look at 1399.154.
Oh, that is the
Cross-referencing.
It goes back.
Okay.
Yeah, I do a lot of cross-referencing.
Okay. Thank you. Thank you.
So it does imply if you just go to the section.
Okay. So again, we're not trying to create a whole separate thing for them to have to do.
Office of Administrative Law doesn't really like duplication.
Perfect. And then lastly, for what I had noted on page 14 of 16, so under I, we have fit or sell. Okay, so this is the audiology aid shall not perform any of the following functions. And then I has fit or sell a hearing aid without possessing a valid hearing aid dispenser's license or a valid hearing aid trainee license.
It's J, just so.
Oh, J, I'm sorry. And then, so since there's a semicolon there, does that mean that the things after that mean you can't do that without a valid dispenser's license? No.
It's each
It's each individual?
each individual lettering.
Oh, I see, there's an or here. Okay, so.
And then I don't know if under K then, so if I is saying you can't fit or sell a hearing aid without possessing a dispensing license or trainee license, do we need to say the same thing under independently adjust hearing aids without a valid license, yada, yada, like we did on J? I guess I don't understand why we're including, are we saying under J, are we including, oh, well, unless you have a valid license, you can't do the things? So is that because we're concerned some people are aides that also have a hearing aid dispensing license and we're trying to clarify? Why did we include that statement in J but not in K? Am I making sense?
No, it makes sense, and actually they could be combined then, really, to say without.
Cochlear implant should not be touched by hearing aid dispenser at all.
Correct, so that should just be separated out.
So you want it to just.
Hearing aids? Or just?
I think you could, in J, I think what we're saying is fit sell or independently adjust hearing aids without possessing a valid hearing aid dispenser's license or trainee license. And then you could leave K, cochlear implants. Yeah, they should never touch cochlear implants. And they shouldn't do the other things under there.
So fit, sell, or independently adjust. And I'm striking out the or and K as well, right? Because that was unintentionally in there.
Edit. I think that was the extent of my comments on the, does anyone else have anything to add or? Okay. Prior to us making a motion, do I need to open it for comment again, or we make the motion and then I open it for comment? Motion first. Okay. So does anyone want to move? There's a motion, suggested motion language on page 2 of 2, the start of the section.
And you would want to use amended rather than noticed in that suggested language.
I move to recommend the regulatory text for Title 16, CR sections 1399.151.2, 1399.151.3, 1399.151.4, 1399.154 through 1399.154.122 and 1399.157 to the board to initiate the rulemaking process as amended and direct board staff to prepare the regulatory text for board review and approval.
Second that motion.
And moderator, we're ready for public comment on the item.
All right, we have a second. We have a motion and a second for agenda item 3. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. As a reminder to our mobile device users, you may need to hit the ellipses button, that's the ... in order to find your hand. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, please. I'm going to call for a vote.
I will call the roll. Dr. White?
Yes, aye, sorry.
No worries. Ms. Chang?
Yes.
Dr. Chambers?
Yes.
Dr. Sanders?
Aye.
The motion carries.
All right. That concludes our agenda items.
Yes, and we will go ahead and now take a 15-minute break while we also move everybody around to start the Speech Language Pathology Practice Committee.
All right, calling to order the Speech Language Pathology Practice Committee at 2:36. And Ms. Burns, would you like to call roll for us, please?
Absolutely. Ms. Dominguez?
Here.
Dr. Chambers?
Here.
You have a quorum.
Thank you. I'd like to ask for public comment. Oh, there's no one here in the meeting room, so there's no members of the public in the meeting room for public comment. I'd like to ask the moderator to open for public comment online.
We are open for public comment for items not on the agenda. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. People will be given 3 minutes to speak, and I'll give you a 30-second warning before your time expires. We're going to take just a few seconds now to see if we have a request for for public comment? Seeing no request for public comment, do you wish to continue with the agenda?
Yes, please. Thank you. I'd like to move to agenda item number 3, discussion and possible action to amend regulations regarding scope of responsibility, duties, and functions of speech-language pathology assistants as stated in Title 16, CCR Section 1399.170.3. So I'd like to ask Ms. Lorenzo to present this agenda item.
Thank you, Ms. Dominguez. On November 30th, 2023, the committee discussed the practice restrictions on FLIPA regarding the performance of oral pharyngeal swallow therapy with volute material. At this meeting, board staff presented to the committee FLIPA practice restrictions in neighboring states, which is attachment A. The committee directed board staff to prepare for the committee an overview of the scope of practice for both the occupational therapy assistant and physical therapist assistant, which is attachment B. If the committee wishes to propose changes to regulations, the following are discussion questions to consider, which will help board staff to draft the text. And so the first question is, should FLIPAs be required to demonstrate competency to perform this therapy? Is it part of the FLIPA program curriculum, or must requirements be specified, and what those requirements should look like? 2 is, when a FLIPA perform this therapy, should they be when should this FLIPA perform this therapy? Should they be required to be supervised for each patient or student for whom they perform this therapy? And then question 3 is, should there be any contraindications that prohibit a SLP from performing the therapy? If so, what should those be? And then 4 is, what level and amount of supervision should a FLIPA have when performing this therapy? Are most of these patients needing this therapy medically fragile, or does it change over the course of the therapy and shows the need for immediate supervision initially? Like I said, we have the attachment 1 regarding practice restrictions in neighboring states and ASHA. And then attachment B is the scope of practice of assistance and other healing arts.
Thank you. We'll open for committee comments and discussion. I'll go ahead and start. I think I was getting myself into the weeds on this. There's a lot of moving pieces. I did start to look at two SLPA programs in our state. Both of them are in Southern California that I looked at. And I didn't see anything specific, at least just for face value, that discussed anything regarding swallowing disorders or even feeding. I think it would be worth seeing if we can get more information on the actual curriculum for those courses listed and see what that entails. I also think it would be good to look at the course curriculum for the CODAs. Again, as I was getting more into this,
What's the code?
The occupational therapy assistants.
Okay.
Are certified. Look at their curriculum to see if their instruction includes feeding. I have seen, also looking into all this, I've seen some job descriptions for CODAs, some listings when they're looking for positions. that they're listing feeding therapy. So that's what leads me to think, okay, so do they have curriculum for feeding? I know the CODAs have advanced practice. OT. Yeah, OT has advanced practice criteria, so those who complete certain requirements are able to do therapy for swallowing disorders in addition to the feeding. And, you know, they describe an occupation as anything, you know, that pertains to part of a person's day or tasks that need to be done, and eating is one of those. So again, why I was thinking, okay, so if CODAs are doing this, but we need to verify, is that in their training?
Or that they should be doing it?
Right. And we have speech pathologists who we do have education and training on this, and then if we're working in collaboration with an assistant, you know, how is that parallel, not parallel? I think that just needs to be further investigated as well. Okay. Because the CODAs are doing it, why are the CODAs doing it? Do they have, is there, again, for the CODAs, is there advanced practice? I did find a document that we also may want to look at. It's from several years back. It's the American Journal of OT, where they, in that article, talks about like the level of practice, like somebody says more advanced training, and CODA is listed in that. And there's a grid that says what the OT can do and what the CODA can do based on oral phase, right, versus pharyngeal phase. So I think it would be worth looking at that. So CODAs are being cleared to do that. Again, it's a few years back. I'd like to see if there is a more recent one. So it's from the American Journal of Occupational Therapy. And then there's some paragraphs in there that talks about education and training and competency.
We would have to take a look. We do get each speech language pathology assistant program that's an associate's program does send us an entire workbook on their plan. That's the initial, and then they'll send us updates if they change their curriculum. I can go and look at a couple and see what we can find in there. And then kind of we can research from there. I don't know as much about occupational therapy, but we can also loop them in. I know they were also looking for an executive officer as well, but I can try and find out who to talk to over there to start that conversation.
That's my understanding for OT, that it's advanced practice, so they are required to take additional training and courses. I couldn't find any information specifically if in
CODA.
A CODA, if they work under that, does that mean they're permitted to perform that? That wasn't clear, but we could definitely reach out to the board to ask for clarification.
Because I did see, again, just poking around, even at Indeed, that those feeding was mentioned as one of the skill sets that they wanted. This OT does it. It was a CODA job.
No, I know.
Right?
Because if you look at the OT, that's who's going to supervise them. It's because they perform it. So they were supporting them.
Right, but a speech pathologist also does feeding and swallowing. So again, having that discussion, we have CODAs doing it. However, we need to make sure that.
I was going to say that sometimes because the job description says it doesn't mean it's actually legal or right, but we do find that out in the this SLPA world already, right? Aids being advertised, but all the duties say SLPA duties. So we do find that currently.
And it's also saying oral pharyngeal swallowing different than, you know, just the whole phase of the swallowing. So even just the mechanics and the anatomy of the.
And our statute has the blanket provision, right?
And I know in the occupational therapy profession, you know, they are doing spoon to mouth or hand to mouth training. So again, is that in Dakota's curriculum, education? I think before we even move with changing any of this, I think we do need to look at those two aspects.
That would be helpful.
You happen to have a year?
I think it was
Or if you could
2018. I think it was 2018.
Okay.
I think it was the Oregon.gov website references the article.
Yeah.
Any other notes? And it was very helpful that you did include on page 3 of 6 the treatments performed by occupational therapy assistants. And interesting in section, the first A, capital A, the occupational therapy assistant may contribute to the evaluation process by gathering data, administering standardized tests, and reporting observations. I did notice that, and I'm wondering, is this for someone who's working under OTR that has advanced practice, or this is just general? They're able to do that too. And it doesn't appear that the speech pathology assistants are able to do that either. So I think that encompasses this issue as well. So I guess back to your first question, is this therapy part of the curriculum? And must requirements be specified? I think if we can utilize your resources and see.
We'll take a look. My guess would be is that the swallowing may not be the bigger component, since most SLPAs are going into schools and working with children on the speech side, not as much on the swallowing. But we definitely can take a look.
Yeah. If they're focusing on the oral component, right, in the schools, like with the OTs, that's the hand to the mouth or the spoon to the mouth.
Rather than
oral phase. Oral phase. It is part of it.
So not
Right.
liquid, we're talking about both facts. That's a
And they're eating a lot of graham crackers and things
different
like that.
category.
Yeah.
We'll
And
take
it
a
does
look through
feel
that.
like a lot of states do not allow the SLPAs to engage in the activities regarding feeding and swallowing. But again, looking at the codas, I like to see how's that aligned.
So if we're unnecessarily limiting our SLPAs.
Exactly.
Yeah, we could do more research on it. Because I did notice, that was the one thing I did notice, I was like, well, OTs can do swallowing, so now what's the difference, like, in the assistants?
Yes.
So, yeah, we'll definitely do research on SLPA programs and then
Dakota program.
see what those students.
Yeah.
We can reach out to their board about that.
Yeah.
Because my guess is, just from the vague memory of the last SLPA program update, I don't remember seeing a lot on swallowing, so I will go double check. But
Yeah, and if it's not on there, how do we find out exactly like what's in the universal job description for a CODA? Yeah, because I haven't seen 100% of the job postings say feeding, but there are several that do.
And in pediatric settings.
Yes. Yes.
So we could definitely direct it more towards the OTs with that advanced practice for that swallowing and ask how those assistants work.
Yes.
That
Yes.
specific, just that specific area.
Right, and what competencies are they having them
For the
show?
assistants.
Yes.
Because
Right.
the regulations do specify competency for the OTs. I just haven't.
Right, for CODAs. Okay.
I'm sure there's there's gotta be something somewhere.
Again, just like our own laws and regs, sometimes
Yes.
there's a lot that's left to the profession to
Yeah.
take care of as part of your job as a supervisor,
Mhm.
right? You're ensuring that they're adequately trained and supervised.
Right.
And there was a time for most all boards where we didn't really specify a whole lot
Mhm.
of that.
Mhm.
It's kind of up to you as the professional, which meant a great wide variety of
Right.
what's going on there.
Yes. Leaves it up to interpretation, just like the fees did.
If we do find that there's not a lot in the curriculum, my guess is then we'd want to look at some sort of competency model that
Mhm.
if we're going to go away from what other states are also prohibiting, then maybe we want to make sure that we specify at least.
Right, right. So at this point, not deviating from what the majority is doing, including ASHA. But again, are we, I'd like to tell you, term that, are we limiting,
Yeah, unnecessarily
limiting, our assistants?
Which, I mean, to be fair, right, so then in skilled nursing facilities, you could be using more SLPAs, but currently you're not able to, so.
Or people that are thinking, oh, I do want to work on swallowing, but this is kind of the path that's been established, but not thinking that you could be an SO.
Right.
So
Yeah.
does that change the landscape
Right.
of that field?
And this is just a side note, because also there's certain payers that don't reimburse for services provided by assistants, especially government agencies, right? So no, they might not see the adults so much, but the pediatric population that could benefit from this service is probably right now getting it, or potentially getting it from CODA versus.
Very possibly, because we limit it, yeah.
Even who does supervision of some of that? Some of those are in hospitals, and so you do have speech language pathologists that are overseeing the like therapists. So where does one begin, or what is that? In their oversight.
It does get quite gray in the middle there.
Yeah.
I have received emails regarding those kind of questions where SLPs are working with OT for training.
Yeah, but don't we have a statement saying that we're not supposed to train on
You can supervise, I think it's on our
Is it-
website and under the practice issues.
Can we look at that? What is it? Yeah. With the
If you go to
SLPs?
our website, there is a speech language pathologist supervising occupational
That's
therapist.
what I wanted to, yeah. Can we look at that?
Out. The requirements.
So, contact at the, okay. Okay. Thus, it is legally possible for OTs to obtain supervised on-the-job training from SLPs, provided OTs become qualified aides and are registered with the board as such. Let's see. The OTs become qualified aides.
And mind
What
you,
is that?
this is a older legal opinion that was it's been on our website for quite some time. But it does talk about how the OTs and the advanced practice certification and swallowing assessment.
Okay, so this is another version that different from what I previously seen that the physiologists weren't supposed to, but now this has modified a little bit. Okay.
So whether they're an OT, whether they're an OT, is it irrelevant because they're an
Why does it say OTs become qualified aides and are registered with the board as such? This is legally possible to attend supervision for the supervisor.
And he was right on the.
If you're going to
So the
continuously work under
OT
the
is going to be an aid? Why would they- Mhm.
This hasn't been looked at in quite
Oh.
some time, I would suggest. So it is old language. So I will caveat that. It has been here for quite some time.
It is something we could get clarified, for the next meeting.
Yes.
There does seem to be a lot of crossover. And we've also had emails that are, the speech pathologist is the, what is it, the owner operator, or maybe it's just the supervisor at a rehab clinic, and then they have different types of therapists that all do report to them, but it's not like that's their supervisor as well.
Like the director of rehab?
I think so, yeah. So then there's kind of that interesting part.
More administrative.
Yeah,
Yeah, usually that's where they're working at, is multi.
yeah, rehab clinic.
Making sure the minutes are there, or
I think
the
it's
therapy
back to
and
their
frequency.
curriculum
Mhm.
training.
We have to see what that looks like.
You have to see what that looks like.
Uh-huh.
It'd be worth looking at, as well as updating probably this
This as well.
webpage as well.
Okay.
One of the many pages we'd
Yeah,
like to
that's
update and
okay,
look
yeah.
at.
Thank you.
We can definitely do that.
Okay,
My guess is then 2, 3, and 4, we want to come back to after we look at some more curriculum,
Yes, yes.
and then get more into the nitty gritty of the therapies and when and how and who.
Exactly, yes. And I can email that article.
That'd be
Oh,
great. And that way we can start from there, and then I'll go back and look at some of the curriculums
Right.
that were get sent. So,
Okay.
yeah.
I could reach out to the safety board.
Thank you.
Get some insight from their policy folks.
Want to do public comment? There's no one in the room for public comment, so I'd like to ask the moderator to open public comment regarding this agenda item number 3.
We are open for public comment on agenda item 3. Now is the time to raise your hand by tapping that hand button at the bottom of your screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, we'll move on to the next agenda item. Thank you. And moving on to agenda item number 4, discussion and possible action to amend regulations regarding general application requirements and speech-language pathology and audiology aid requirements as stated in Title 16, CCR sections 1399.151.2, 1399.151.3, 1399.151.4, 1399.154 through 1399.154.12 and 1399.157. So I'd like to ask Ms. Alonso to present this agenda item.
Thank you, Ms. Dominguez. On November 30th, 2023, the committee directed board staff to amend the draft proposed regulatory language that will implement statutory changes for SLP aids, and the following changes were made. We amended section 1399.154.1 to require each supervisor to register the aid if the aid has multiple supervisors. And we also amended section 1399.154.2D to say, and all managed care, and added subsection G through K to require supervisors to have practice experience prior to supervision, notify their aides of disciplinary action against the supervisor's license, and complete continuing education and supervision, and review laws and regulations with the aide, and provide the aide with a plan to handle emergencies. In preparing the text for the committee's discussion, board staff and DCA Legal has identified the following changes. We made grammatical corrections in section 1399.154.2. We also specify that the supervisor is required to maintain their course completion of their supervision training for 4 years after the renewal period in which it was earned, if they wish to apply it towards continuing professional development requirement. And we also amended section 1399.154.7 to add aid after speech language pathology and revise the Business of Profession Code section reference in the text. Also included are revisions to the text regarding the audiology practice committee that were discussed at their meeting on September 5th, 2024, that we used to prepare for their meeting. We do have a discussion question, which is the current, what the supervision requirement should be for the aid. Should it be, currently it says that the supervisor must be physically present while the SLP aid is assisting with patients unless an alternative plan of supervision has been approved by the board. So we just wanted to make sure that the committee was okay with that language or if they would like to revise the language.
So I'll open it up for committee discussion. My question is for 1399.154.2 C, on being physically present while the speech language pathology aid is assisting with patients unless an alternative plan. So I know that in the audiology section, there's the definitions of the types of supervision. So to make it more in line, could we use the word or the term immediate supervision to have it go in line with audiology verbiage, or leave it as this?
Well, I think that's
because
where
physically present is the same as, right, the immediate supervision?
because it was never specified before and the aides were always just supposed to be assisting you while you're in the room with the patient. Once we had all of the responsibilities of the aide supervisor and the training of aides and the supervision of aides, once we did it for the audiology, it seemed pretty scant to just have the speech that it was just, you need to be in the room with them at the time. The hardest part being we haven't gotten very much input from any of our licensees that actually have a speech aid registered with the board. So there's not been a whole lot of input. And I remember Holly had not had an aid, and you don't have an aid, right?
No.
So
I've had in the past, but
it's been a difficulty of kind of trying to figure out, is the lack of specificity because the use of a speech pathology aid is so different than the audiology aid and the amount of things they're doing? Is that maybe the outgrowth of that, right? If you just need an assistant in the room with you while you're doing your work, then that current provision works. It's not very, significant or clear, but it's if it works, it works. But at least for the audiology ones, it's been important to specify levels and what you're doing. Right. But I think that's been the hard part is there's not a lot of speech aids to start with, and then there's not a whole lot of input on it.
And that was my, go ahead.
I would also recommend that you might have to either remove or clarify the use of a supported. I think that's a little vague in the language. So I think that's the only concern I have is that if it's just the aide, the supervisor has to be in the room with the aide, then you have to take that part language.
Yeah, it makes sense.
There is no other option.
How many aides do we have?
Hold on a
Like,
second.
and then 2024,
they're all
a lot
together.
of,
They're all together.
Yeah, unfortunately, the data doesn't separate
Yeah,
them
so we don't know
easily.
how many SLP aids you have versus.
There's only, let's see, 285 aides at the moment, total,
we don't know how many of those are,
and much of them are audiology.
seems like they have a lot more flexibility in their role too. So it would be interesting.
We can find the data next time so we can discuss it. It's just this package was already moving, so the hesitancy was, do we want to let it go with the moment? Or at least get rid of the part where it says an alternative plan approved by the board, because there's not a lot of criteria and specificity to that. So I think that's where we would run into problems, right? So under what reasons would the board, we would get it and say, no, that's denied. Usually you put in some sort of criteria for denial or something. Now, mind you, if we hadn't touched that section, it's a different conversation, but we're already touching the section.
Yeah.
So they're going to review it and say, this lacks clarity, and we're going to say, no, I think you're right.
Yeah. So have you had any requests for alternative plan of supervision?
We have to check with Lisa on that.
And if so, what were those?
We can go ahead
and then I would say take it out.
Take it out, yeah.
But if you have, I think that's going to
What does it look like and what is it then?
Right. Yeah. Really, what was that? And were they pushing that person to work out of scope, or so? Were there any requests?
Yeah, we can go ahead and look at that, and then also get the data on how many of the aids are speech versus audiology for next time.
Yeah.
To be clear, the current expectation is that they are physically present?
Yeah. Unless there's an alternative plan. Right?
And that would be, and I don't, as the AEO and now as the interim, I don't review those plans. The licensing staff are. My guess is they don't actually get any requests about it, or they've always had some sort of general idea.
If you get a request and it's probably out of scope of practice, they're wanting to be.
That, I was going to say, that's probably also the other alternative, is that when they see the alternative, it's to do slip of work, and we have to say, sorry, that's outside the scope.
Right.
As you read through some of these other state regulations, everything is saying supervisor. You know, you're not doing anything independently. So I'm
Yeah.
fine that
You're just not, yeah. We can verify, and then if that's the direction, is that you're good with the text removing that, if what we verify is that it's,
Yes.
because it'll come to the board at the next meeting anyways, right, for the 8th? No, it'll be sometime next year. Yeah.
Before, so it'll be a while.
It'll be a bit, okay,
Oh.
yeah, all right.
So it does have to circle back to the board at some point.
Yeah,
Right.
because the audiologies approved it as they amended it, and then if you guys were good, then it would be both of you recommending to the board to move along. Before we come to the board, we write the initial statement, or we try to draft it. So that way we find any other little things we might have missed, hopefully. That's always the attempt.
Yeah.
Yeah.
Okay.
So, but we can look into that.
And then report back at
Yeah.
to the committee.
And that way you could have that information. Then the committee could move at that
Yes.
point.
Okay.
That sounds good.
So there's nothing that we're moving forward to make a motion on or a second on?
Not yet, because we'll
Okay.
find out about what kind of alternative plans we've been getting
Okay.
and whether or not they're all trying to be
Right.
outside of the scope and slip us.
Yes,
So.
okay. So at this point, ask for public comment?
Yeah.
Okay. There's no one
We're not going to make
here.
a motion at the moment.
Okay, for public comment in the room, so I'd like to ask the moderator to open for public comment on this agenda item.
We are open for public comment on agenda item 4. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, so continue. Thank you. All right, so There's no public comment. I'll go ahead and adjourn the process committee for speech language pathology at this time and closing the meeting out for the day as well.
Thank you, and we'll see you all tomorrow morning at 9 a.m.
Thank you.